The main challenges in immunotherapy today is probably to be able to identify the patients benefiting from the strategy. The main problem we have seen strikingly here in ESMO Asia is the future availability, accessibility to these very expensive compounds. So we would like to be able to, I would say, predict which patients would benefit significantly from the drug. We are now using PD-L1, which we still, in retrospective data set, find a little bit unsatisfactory in terms of predictive ability. But we still don't have very strong prospective data set using PD-L1 as a stratification factor, for example. And this afternoon in the presidential session, the first trial using this biomarker as a stratification factor will be presented. It's a KEYNOTE-010 comparing Pembrolizumab to docetaxel. We know from press release that this trial is positive, that Pembrolizumab is better than docetaxel, but the extent of variation of the benefit according to the PD-L1 status will be of great interest for the community. Of course, with the rough number, we'd like to see the numbers to see what the benefit looks like. Well, the main challenge, I would say, for non-small cell lung cancer is to know in which line we should use immunotherapy. Because if we're able to select or predict which patient benefits, it might also be a very good strategy for frontline therapy. In frontline therapy, you could also imagine to combine two checkpoints, like we discussed before, to combine with chemo. So the main challenge is to really position in the sequence of treatment the immunotherapy at the right place. I still believe that the main hope is potentially to have a chemotherapy-free survival time. So I like the idea that you could move for 1 year, 2 years, I hope more, without having any chemo, which is quite toxic.